welcome everyone for today's session. On behalf of Zydus, I'm Dr. Suyash Bharat. Uh, it's our it's a great opportunity for us to attend this today's session by Dr. Tejinder Singh sir, and and we would like to thank MHG for this opportunity. And for further discussion, I'd like to hand over the session to Dr. Amit Khurana sir. Over to you, sir.
Thank you, Dr. Suyash. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Tajinder Singh from New Delhi, and he's going to lecture us on utility of immunohistochemistry in diagnostic hematology, as well as in lymphoproliferative and plasma cell neoplasms. This is the part 2 of the IHC webinar. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team from Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Tajinder Singh from Gurugram. All our discussants were themselves very eminent hematopathologists, and you participants for sparing your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 14th of September 2025, from 11:30 a.m. Indian Standard Time and 8 a.m. French time, your Dr. Regis Pifoldi Lator from Paris, France, speaking to us on Fanconi's constitutional aplastic anemia. Let me introduce our discussants for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussants for the day. So these are our discussions for the day. And now it's a time to introduce our guest speaker for the day. We are no other than Dr. Tajinder Singh from New Delhi. He does not require any introduction, but it's my formal duty to introduce Dr. Tajinder Singh, sir. Dr. Tajinder Singh is Senior Consultant at OnQuest Lab, Gurugram, former Dean of Faculty of Medical Sciences at Delhi University, formerly Professor and Head, Department of Pathology at Maulana Azad Medical College, Delhi. He is also the past President of Indian Society of Pathologists and Microbiologists, also the past President of Indian Society of Hematology and Blood Transfusion, a Fellow in Indian College of Pathologists, as well as also the Fellow of Indian Society of Hematology and Blood Transfusion. And he has authored 7 books in hematology. Today, he's with us and is going to lecture us on utility of immunohistochemistry in diagnostic hematology, part 2, that is on lymphoproliferative and plasma cell neoplasms. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, Dr. Khurana. It is always a pleasure to be there with you. Good evening, everybody, and thanks to Professor M.B. Agarwal for inviting me to be part of this program. What I'm going to talk about today is utility of immunohistochemistry in diagnosis of lymphoproliferative disorders and plasma cell neoplasms. Now, this is in continuation of the last meeting, in which what I had discussed was in acute leukemias and MDS, is there any role of immunohistochemistry? So what I had covered was, number one, how to diagnose acute leukemias using peripheral smears and bone marrow aspirate, their morphology, cytochemistry, cytogenetics, molecular, and then blast immunophenotyping with lineage. Here I had used immunohistochemistry for confirmation of the lineage and diagnosis, though of course we all know that flow cytometry is the requirement, but in all cases flow cytometry is not possible. So I had discussed about immunohistochemistry of BALL, TALL, immunohistochemistry of AML, and then detection of relapse. Before starting that, what I had done was shown you the normal myeloid precursors, including CD34 and promyelocytes, which are at the paratrabecular location, and then the normal lymphoid cells, CD3, CD20. Of course, CD3 are more than CD20 cells, the megakaryocytes and their distribution. And then for an example, what I had shown was in BALL, the myeloid markers were negative, and which were the markers which were positive? Those were CD34, TDT, CD20 was negative. However, PAX5 and CD10 and CD79A, these three B cell markers or precursor B cell markers were positive. T cell markers, CD3 was negative and CD117 was negative. By this method, we are able to pick up AML hypoplastic type. For example, it is shown here, hypoplastic marrow with a cellularity of only 15 to 20%. However, some cells were seen in between the fat cells, CD34, and then these were positive with CD117. Similarly, we could pick up cases of AML with marrow fibrosis, extensive marrow fibrosis. There is dry tap. However, what we find is that there are blast cells, there are megakaryocytes, and then by markers we could diagnose. So today I'm going to take up lymphoproliferative disorders as well as multiple myeloma. And we all know that in the Western world, lymphoma is the most common hematologic malignancy, and therefore accurate staging of the patient with lymphoma is essential, and also to determine the extent of the initial disease. Bone marrow biopsy is the gold standard for assessing the bone marrow involvement. And what we do is not only we study the morphology, but also immunohistochemistry. Now, immunohistochemistry helps us in knowing the lineage of the lymphoma deposit in the bone marrow. Of course, the other ancillary investigations are always carried out, which may include flow cytometry and, of course, the molecular studies. So the first step is, how do we diagnose lymphomas? First is clinical features, radiological findings, and the lymph node biopsy. And lymph node biopsy, of course, is the gold standard, as it allows for the assessment of the whole lymph node architecture. And then we study the histopathology, carry out immunohistochemistry on an entire lymph node, and other studies like EBER and FISH may be carried out depending upon from case to case. So the final diagnosis is made. A, is it non-Hodgkin lymphoma or is it Hodgkin's disease? If it is non-Hodgkin lymphoma, are we dealing with B, NHL or TNHL? And then we classify as per WHO classification. But before we start the treatment, what is needed is staging of the lymphomas. So how do we work up in a case of lymphoma to stage the disease and extent of the lymphoma? So we examine for lymph nodes, liver, spleen. Peripheral smear evaluation for lymphoma spillover is essential. And then, of course, beta-2 microglobulin, LDH, for tumor burden. And then we all know that if liver is involved, it becomes stage 4. If the bone marrow biopsy or bone marrow aspirate, both are involved, it becomes stage 4. So the staging is of great importance before we start the management of these cases. Now, this is just to show you a picture of the staging of lymphomas so that we can do the prognosis and the treatment planning. Now, what are the Lugano classification recommendations? They have mentioned that PET-CT should be carried out for staging of Hodgkin's and non-Hodgkin's, especially if these are FDG avid cases, so that bone marrow involvement can be detected. But if PET-CT in bone marrow is negative, then bone marrow biopsy must be carried out. So PET-CT for staging of Hodgkin and non-Hodgkin, if it is negative. And then also if the patient has got cytopenia, again bone marrow biopsy is must. And then to know the marrow reserve is how much normal hemopoiesis, erythropoiesis, megakaryopoiesis is present, because then we know as we institute chemotherapy, the patients undergo cytopenias. So we should be aware of the fact that how much marrow reserve is present in a particular case. And what Lugano recommends is 2.5 centimeter unilateral bone marrow biopsy, but immunohistochemistry is must on that bone marrow biopsy. And not only we are studying and looking for lymphoma, but we are also studying if the patient has got cytopenias, fever, infection, any fungal infection, and tuberculosis. PET-CT is recommended as a standard modality for staging and response as per the Lugano guidelines. However, now it is well known that bone marrow involvement assessment is must in all lymphoma cases, including cases of DLBCL. However, in some places, we find that the bone marrow involvement criteria are not well defined. And therefore, in those places, especially in developing countries, this problem of involvement of the bone marrow by bone marrow defined biopsy does occur. But at the same time, we find that the PET-CT is quite expensive in these developing countries, and all the patients are not subjected to PET-CTs, but bone marrow biopsy is carried out. And in case the bone marrow biopsy is positive, it becomes a case of stage 4. It is a big study of more than 3,000 cases in which the blue color is indicating the bone marrow biopsy findings. The orange color is indicating the PET only, and the gray is indicating where the positivity is seen by both bone marrow biopsy as well as by PET-CT. Now it is very, very obvious whether these are marginal zone lymphomas, T-cell lymphomas, follicular lymphomas, or DLBCL. The bone marrow biopsy positivity rate is highest with the bone marrow trephine biopsy. And secondly, it is followed by when we have bone marrow biopsy plus PET-CT, because this is the gray area in which we find positivity is occurring. PET-CT is the least sensitive in picking up the cases with bone marrow involvement. So therefore, the Lugano classification has provided improvements in lymphoma staging and response evaluation. And therefore, nowadays, bone marrow biopsy with immunohistochemistry is carried out at almost all centers across the globe. Before we go on to the bone marrow trephine biopsy, we must examine the peripheral blood and look for any spillover. Because if the peripheral blood is involved, there is spillover into the peripheral blood, then the bone marrow biopsy is also is going to indicate the same. So already the patient is in stage 4. But then if we do the bone marrow biopsy, we get an idea about the pattern of involvement by the Hodgkin's or the non-Hodgkin's lymphoma, the tumor load, how much tumor load is present and how much marrow reserve is present. So what I'm going to talk about is, first I'll speak about the bone marrow biopsy in lymphoid leukemias or lymphoproliferative disorders, then bone marrow biopsy in non-Hodgkin's, then bone marrow biopsy in Hodgkin's disease, and finally I'll go on to multiple myeloma. Now, this is the NHL spillover into the peripheral blood. You can look at the morphology. These are the large lymphoma cells. This is a lymphocyte. And this is another case where you find large lymphoma cells. These are both the cases of DLBCL. And the third one is a case of Burkitt lymphoma, in which you find the typical cells having basophilic cytoplasm and the cytoplasmic vacuolation. And bone marrow involvement, we all know, is a major prognostic factor. However, in some cases where we need to do flow cytometry, it can be carried out even on the peripheral blood where the spillover has occurred. Now, what is the incidence of marrow involvement? If we look at the incidence of marrow involvement in various studies, what we find is that the small lymphocytic lymphoma the percentage of involvement is more than 75%. Mantle cell lymphoma, follicular lymphoma, splenic marginal zone lymphoma, in all the three, we find that it varies from 55 to 100% marrow involvement could occur in these cases. The least involvement is seen in DLBCL, where the involvement percentage is only 20 to 30%. On the other hand, in T cell lymphomas, we find that with hepatosplenic T cell lymphoma, the marrow involvement occurs in more than 95% of the cases. We start with one case, a 45 years old male patient who had fever, loss of weight, balance for 3 months. Peripheral lymph nodes were not palpable. On the other hand, the X-ray chest indicating there is a mediastinal lymph node and large mass. Bone marrow aspirate was a dry tap, but the clinical impression based on the X-ray chest, CT, etc., was that there is a lymphoma. You can see the involvement in the CT, and here you find the lymph node mass is present in the mediastinum on X-ray chest. So bone marrow biopsy was carried out to see if the lymphoma involvement is there or not. And then immunohistochemistry on the bone marrow biopsy is carried out for final diagnosis. Since this patient didn't have peripheral lymph nodes, so the bone marrow biopsy was carried out. Now, this is the bone marrow biopsy. What we find here in this bone marrow biopsy in low power is that there is fibrosis of the marrow throughout. That is number one. Number two, in between the fibrous tissue, what we are finding are the cells are present. Now, which are these cells? You can see on high power, polymorphs are present, lymphoid cells are present throughout, few eosinophils are seen, few plasma cells are seen, and there was an occasional large cell with prominent nucleolus. So the overall picture was fibrotic nodules in the bone marrow, with a polymorphic infiltrate consisting of eosinophils, plasma cells, and Reed-Sternberg cells, which had prominent nucleoli. These were few, and these were seen amongst the other polymorphic or the pleomorphic picture of lymphocytes, plasma cells, and eosinophils. Then the CD30 and CD15 were carried out. What you find in CD30, you can see the prominent paranucleolar area where you find that these cells are positive. So CD30 was positive and CD15 was positive. Now, based on this, and that there were T lymphocytes in the background. Now, if positive, it becomes a stage 4. So that means here we had a case of Hodgkin's, which was involved bone marrow, and that was a stage 4 case. So bone marrow biopsy in lymphoid leukemias, that is CLL, hairy cell leukemia, splenic marginal zone lymphoma, and so on. Those are the lesions we are going to discuss now. Now, which are the key immunohistochemical markers? There are so many markers nowadays available, and however, the markers which are being commonly used are CD20 for B cell lymphomas, positive in DLBCL, follicular lymphoma, mantle cell lymphomas. Then we have CD3 is positive in T cell non-Hodgkin's lymphomas, CD10, BCL2, and BCL6. Now, BCL2 and BCL2 is mainly expressed in follicular lymphomas and some aggressive B cell lymphomas like DLBCL. BCL6 is positive in DLBCL and also some cases of follicular lymphoma. Now, cyclin D1 is a very specific marker. Besides the other B cell markers, which are positive in this case, but cyclin D1 is positive in mantle cell lymphoma. CD5 is expressed in CLL. We know very well that CLL is a B cell neoplasm, B cell leukemia. However, CD5 is a T cell marker, and both B and T cell markers are positive. Ki67 gets us the proliferation index. And of course, the CD23 is again used to differentiate between mantle cell lymphoma as well as CLL. Now, PAX5 is a nuclear marker, and this is used for differentiating between B and T cell non-Hodgkin lymphomas. And of course, CD45 is used for non-Hodgkin lymphoma versus acute leukemia. What we find is that in acute leukemia, CD45 is rather weak, but it is CD45 is positive, strongly positive in most of the cases of non-Hodgkin's lymphoma. First of all, taking up the CLL. Now, you are all aware of the CLL, where we find about 80 to 85%, or maybe even 95% of the lymphoid cells or the mature lymphocytes are present. Not only the mature lymphocytes, but we also find smudge cells, which are seen in the peripheral smear of these cases of CLL. Now, it has got a typical triad which is positive, and this typical triad is CD5, CD19, CD23. Now, these three markers we can do flow cytometry on the peripheral blood, and these three are positive: CD43 and CD200. These are also positive. So, a combination of these three plus CD200. However, if we do immunohistochemistry, so what we find is that CD20 is strongly positive as compared to CD20 on flow cytometry. However, it is negative for CD10 as well as for FMC7. And of course, the two markers which we use for mantle cell lymphoma are cyclin D1 and SOX11. And these are negative. Now, what is atypical CLL? Sometimes we come across cases where we find that the typical picture of CD5, 19, 23 is not positive. What we may find is that CD19 may be negative, then we label, or there may be loss of CD23, so loss of CD5. So these cases are labeled as atypical CLL as per WHO 2022. So here we find that CLL, PLL, that is the old terminology which we still use, where we find that the pro-lymphoid cells vary from 15 to 55%. But we should exclude CLL, PLL when we are dealing with CLL to diagnose it, unless we find that the sum of the cases of CLL, there is a pro-lymphocytic progression of CLL. That is, the disease starts as CLL, diagnosed as CLL, and then gradually the number of pro-lymphocytes keep on increasing beyond 15%, and then we now label it as pro-lymphocytic progression of CLL or small lymphocytic lymphoma. However, the diagnostic criteria remain the same. That is, in the bone marrow, we should find more than 30% of lymphoid cells which are expressing CD19, CD5, and CD23. These are the two cases. And then this is immunohistochemistry in a case of CLL, which we do on the bone marrow trephine biopsy. CD20 is strongly positive. CD5 is positive in these lymphoid cells, and also CD23 are positive. So this can be diagnosed even on flow, and this is on immunohistochemistry. Now, what is the pattern of marrow involvement in CLL, and what does it give us an idea? Now, this pattern of involvement gives a tumor load. This is the diffuse deposit where the whole thing is blue. That means the marrow is totally replaced by these lymphoid cells, and therefore the marrow reserve is less. Then we have interstitial deposit where the tumor load is very low, and we find that only interstitial lymphocytes are present. In the nodular form, where we find these rounded nodules are present, the tumor load is again low. What is the mixed pattern? Mixed pattern is that there is a combination of nodules as well as interstitial pattern. So we find that the highest tumor burden is in diffuse and the minimal is in interstitial deposit. Now, this is the actual picture. Here you find a mixed pattern. That is, you are seeing these nodules of lymphoid cells, as well as the interstitially, there is increase in lymphocytes. And this one, of course, is diffuse, replacing the normal hemopoietic elements. And therefore, these patients develop thrombocytopenia, anemias, neutropenia very fast. This is the interstitial lymphoid infiltrate into the bone marrow. And of course, this is the nodular infiltrate, where the tumor load in these two types of infiltrate is tumor load is low. But whenever we come across a CLL case with nodular deposit, we have to rule out that this is not a normal lymphoid aggregate, because what we find is that in age beyond 50 years of age, we may come across lymphoid aggregates in the bone marrow. And these lymphoid aggregates may resemble the nodular CLL. So we must differentiate the two. But what we find in the lymphoid aggregate is this is the CD3 marker. Here we have used the CD20 marker on the same. And what we find is that the majority of the cells are CD3 positive. On the other hand, CLL is a B cell neoplasm. So, but we find that on CD20, nearly almost all the cells are positive and the CD3 are negative. So here it is CD20 predominant and the lymphoid aggregates are CD3 predominant, or usually there could be even a mixture of both CD20 positive cells and CD3 positive cells in the lymphoid aggregates. Now, what transformations can occur? Number one, what I mentioned was that if more than 15% of the pro-lymphocytes appear gradually over a period of time, this is called pro-lymphocytoid transformation. Sometimes Hodgkin disease may occur. More common than that is the Richter transformation. Now, what is the Richter transformation? The patient has got CLL. There are lymphocytes in the peripheral blood, and these lymphocytes are present in the bone marrow also. Now, gradually, what we find is that the patient's condition deteriorates. Sometimes the peripheral lymph nodes may also appear, but in the bone marrow, I can't show you because those large cells, lymphoma cells, have appeared into the bone marrow. So those lymphoma cells, that is indicative of an aggressive B cell lymphoma, you find that the prognosis of the patient worsens in these cases. What is the differential diagnosis of CLL? It needs to be differentiated from mantle cell lymphoma, monoclonal B lymphocytosis, splenic marginal zone lymphoma, PLL, follicular lymphoma, hairy cell leukemia, NHL spillover, and of course the Waldenstrom macroglobulinemia. Now, this is monoclonal B lymphocytosis. Now, monoclonal B lymphocytosis is a precursor of CLL. And these are all clonal B lymphocytes. That means either these are kappa or lambda, which is better seen on flow cytometry. And the patients with monoclonal B lymphocytosis have an increased risk of CLL at a rate of progression of 1 to 2%. Now, this CLL is preceded by MBL over a period of time. Now, this is a status similar to MGUS. What MGUS is to multiple myeloma, monoclonal B lymphocytosis is to CLL. Now, WHO 22 has classified into low count MBL, MBL of CLL type, and then MBL of non-CLL type. A non-CLL type is on immunophenotyping. That is, sometimes there is loss of CD5, maybe loss of CD19. These are the non-CLL type. And the CLL type is the one in which we find that the lymphoid cells are CD5, CD19, CD23 positive. Mantle cell lymphoma is could be a small cell type, could be large cell type. Small cell type may be confused with CLL, and it is further subclassified into classical mantle cell lymphoma or leukemic non-nodal lymphoma, which is SOX11 negative, while the classical one is SOX11 positive. Now, SOX11 is a new monoclonal antibody, but however, we are using cyclin D1 as well as SOX11 for diagnosis of mantle cell lymphoma. B cells are positive for cyclin D1, SOX11, and CCND1 is positive. But the fact remains that the CD23 is negative. As I said, the trio of CD19, 5, 23 is the diagnostic for CLL. but in mantle cell lymphoma, CD23 is negative. Now, this is the mantle cell lymphoma. This is a large cell type. This is a small cell type, which is there. And the markers, what we find is that the CD20, CD5 are positive, CD23 is negative, and what we find is that the Ki67 is high in mantle cell lymphoma in comparison to CLL. And here we find that cyclin D1 is positive. This is a nuclear stain, and this brown color of the nucleus is positive, indicating that we are dealing with a case of mantle cell lymphoma. Now, PLL has got a very typical morphology. Cells are larger than lymphocyte, and these cells have got a single prominent nucleolus. Prognosis is pretty bad in all cases of PLL, whether it is a BPLL or it is a case of TPLL. Of course, TPLL is rather rare, and there is a moderate splenomegaly, and sometimes it is massive in about two-thirds of the cases. And the prolymphocytes are present in the blood and bone marrow. And BPLL can evolve from BCLL. As I said, that more than 15% can go into transformation into a BPLL. Now, BPLL 2022 WHO has renamed it as splenic diffuse red pulped small B cell lymphoma, because in all these cases the spleen is positive and there are blood lakes which are lined by the tumor cells. CCND3 mutation is a constant finding in these cases. Now, this is TPLL, where we find there is a knobby nucleus, but what we find is that uh, the nucleolus, what we find in BPLL, is missing in these cases of TPLL. CD4 is positive in 75% of the cases, along with the 2, 3, 5, 7, which are the T cell markers. And this is a very aggressive disease and very poor prognosis. Hairy cell leukemia. This is a disease of old age. We are all aware of how the patients present with pancytopenia, splenomegaly, and hairy cells could be seen in the peripheral blood, but more often there is pancytopenia. On the bone marrow imprint smears, or sometimes we get cells on the bone marrow aspirate, we do a trap, that is tartrate resistant acid phosphatase, which is positive. Now, some cases may be associated with autoimmune disease. The diagnosis is difficult to make on flow cytometry because of the fact that the cells are very few on the bone marrow aspirate, because of the fact that here we find that there is an increased reticulin in the bone marrow, and this reticulin fibrils are present around each cells. Therefore, the aspiration is not good. So what we have to do is immunohistochemistry to diagnose. And on HND sections, what we find is a typical fried egg appearance, where you find that the nuclei are distinct and apart from the neighboring nuclei, and the nucleus is seen in the center of the cytoplasm. So this is typical fried egg appearance in hairy cell leukemia. Now, this is also a B cell lymphoproliferative disorder. So CD20 is strongly positive. Cyclin D1 is positive. DBA44, which we were using earlier, used to be positive in almost all cases. Now, the specific marker we are using is annexin A1, which is positive in hairy cell leukemia. On the other hand, if we do a flow cytometry, we find that the CD25, CD19, CD103, CD123, CD200 are positive for hairy cell leukemia. It is essential to diagnose and differentiate hairy cell leukemia from other lymphoproliferative disorders, because the drugs are available for hairy cell leukemia, and it is sort of an indolent, slowly growing tumor. Earlier, we used to have a term called splenic lymphoma with villous lymphocyte. Then it was renamed as splenic marginal zone lymphoma. Here we find the cells are small B cell types, seen usually in people over 50 years of age. there are villous projections, as you can see here. The cytoplasmic projections are in the direction in which we make the smears, and these cells are finely PAS positive. It is again an indolent lymphoma, and needs to be differentiated, should not be confused with hairy cell leukemia. This is a case of splenic marginal zone lymphoma where splenectomy was carried out. And what we can see are the white nodules on the surface of the spleen. And this is CD20 positive, BCL2 positive. However, there is no specific marker for splenic marginal zone lymphoma. Now, these were those cases where we find that leukemic presentation is present. Now we go on to the bone marrow biopsy in non-Hodgkin's lymphoma. What you can see here is a bone marrow trifine biopsy, and there are multiple nodules resembling a follicular lymphoma involvement in a particular case. Now, what is the idea of doing bone marrow biopsy in lymphomas? Number one is staging. As I said, the staging is essential, staging of the non-Hodgkin's lymphoma, and then sometimes to establish the diagnosis of primary lymphoma of the bone marrow, because peripheral lymph nodes may not be palpable, and in those cases, bone marrow biopsy, if carried out and is positive, then indicates that there is a primary lymphoma of the bone marrow. To see the marrow reserve, here you can find wherever there are fat cells, that is the normal marrow in between, and this is the lymphoma involvement, to monitor the response to treatment. Then we have what is the pattern of marrow involvement and what does it indicate? Again, here, like CLL, you find the whole bone marrow is blue, indicating that there is a diffuse involvement of the bone marrow, and the hemopoietic precursors, megakaryocytes, erythroid, myeloid cells are diminished. Now, these are the cases who develop neutropenia, thrombocytopenia. Excuse me. Then we have cases in which there is a focal deposit only, and then there are cases where you find that the involvement is in the paratrabecular areas. The lymphoma deposit is in the paratrabecular area, which occurs in follicular lymphoma. Now, this is the focal deposit, as we saw the nodular deposit in cases of CLL. This is the diffuse deposit. The whole marrow is replaced by sheets of these lymphoid cells. And here you find that this is a bony trabeculae, and the bony trabeculae are surrounded by the lymphoma involvement. And this is the CD20 positive in the paratrabecular area. Here again, you find that the lymphoma is involved in the paratrabecular area. This is mostly seen in follicular, but could also be seen in mantle cell lymphoma also. And whenever there is a paratrabecular involvement, in the area of involvement, there is a significant fibrosis also. And therefore, these cells may not be aspirable in a bone marrow aspirate. Now, what about the BCL2 and BCL6 expression and any relationship with prognosis? Because some of the cases we find, say, especially the follicular lymphoma is BCL2 positive. BCL6 is positive only in 13% of the cases. And it is seen that the cases which are BCL2 positive, these have got a worse prognosis in comparison to BCL6 positive, which is seen in some cases of follicular lymphoma and some cases of DLBCL. Now, these cases have got a better prognosis. Now, this is the case of DLBCL, where you find that the cells are pretty large, and of course, variation in the cell size. Here also you can see the large cells, and these are CD20 positive on immunohistochemistry. There are different subtypes of DLBCL, and depending upon the morphology, subclassification of the type occurs. Non-aspirable lymphomas in the bone marrow. Now, as I said, that whenever there is a fibrosis in the bone marrow, whether it is hairy cell leukemia, whether it is a T cell NHL or it is a B cell NHL, if fibrosis occurs due to increased reticuli, those lymphomas may not be aspirable, or it may be a suboptimal bone marrow aspirate. Similarly, in anaplastic large cell lymphoma, in Hodgkin's disease, there is a considerable reticulin increase, as a result of which we find that the aspiration, if we do, doesn't indicate or may give suboptimal aspirate, and we may miss the lymphoma involvement. Now, this is a T non-Hodgkin's lymphoma. There is a marrow fibrosis throughout. Usually, there is a dry tap, or it may be a suboptimal aspirate. And what we find here, that it is CD3 positive and is CD20 negative. This is anaplastic large cell lymphoma, the typical appearance of anaplastic large cell lymphoma. This is on bone marrow aspirate. And here also we find that the aspirate is not good. These cases are ALK positive anaplastic large cell lymphoma, and they appear Hodgkin-like and composite. Most of the patient demonstrate the common type with sheets of these large lymphoid cells. ALCL is CD30 positive and is CD3 negative, as you can see here, CD3 negative and CD30 positive. It doesn't mean that the B cell lymphomas are not associated with fibrosis. Good number, about 10 to 15% of the cases, do demonstrate varying degree of fibrosis in B non-Hodgkin's lymphoma also, and therefore the aspiration is not good. So we have to do a refined biopsy and carry out immunohistochemistry to diagnose whether it is B NHL or T NHL. This is CD20 positive. Then we go on to Hodgkin's lymphoma, and what we find is that lymphocytic predominant type, the good prognosis type of Hodgkin's, is not very commonly involving the bone marrow. That means the bone marrow involvement is rather uncommon in these cases. However, in mixed cellular type, we find that the bone marrow is commonly involved, and also in the lymphocytic depletion type. If case the bone marrow is involved, it indicates it is a disseminated disease. It is a case of stage 4, and the significant overall survival and disease-free survival is low in these cases. The patterns of marrow involvement could be focal or diffuse, and this is to show you a focal deposit in a bone marrow refined biopsy where we find multiple fibrotic nodules. Somehow, it is seen that the Hodgkin disease induces bone marrow fibrosis in almost all cases wherever the bone marrow is involved, except in cases which are immunosuppressed or HIV positive. Now, this is a nodular lymphoma, and this is a diffuse one. Here you find that the whole biopsy on either side of the bony trabeculae is involved, and there is a extensive fibrosis. Because of the extensive fibrosis, we find that the aspirate may be a dry tap, or we may find very few cells, and we may miss that the patient has got Hodgkin's lymphoma. And that is where we find that the bone marrow biopsy is always useful in cases of lymphomas, especially those associated with marrow fibrosis. And this is a picture on HND where we find eosinophils, lymphocytes, few Reed-Sternberg cells, and of course there is extensive increase in reticulin. Now, the markers which are useful are CD30 and CD15. CD30 is strongly positive in the Reed-Sternberg cells, CD15 frequently. PAX5 is positive but weakly. And PAX5, of course, we have to keep in mind, is also a B cell lineage marker. And now we believe that the Reed-Sternberg cells probably belong to the B cell lineage. Then MUM1, BCL2. The cases which are associated with the Epstein-Barr virus, Hodgkin's, those are EBER positive. And the Reed-Sternberg cells are weakly positive with CD20 also. Now, this is from a bone marrow involved case. What we find is PAX5 is positive in the Reed-Sternberg cells, though weakly. CD30 is strongly positive, and the lymphocytes which are present in the background in the involved area, we find that most of the cells are CD3 positive T cells. Now, going on to T non-Hodgkin's lymphomas, we find that T large granular lymphocytic leukemia is rather uncommon, but these are the cases which may be associated with cytopenias. It is a chronic indolent disorder, and we find that the cells are CD3 positive and also CD8 positive, indicating that these are T cell large granular lymphocytes. And then we find that the CD57 positivity confirms the diagnosis of LGL. On the other hand, the hepatosplenic T cell lymphoma are CD56 positive. CD56 positive T cell lymphomas are very, very aggressive. If we find an aberrant expression of CD16, the prognosis worsens in these cases. On morphology, the peripheral blood gives a beautiful picture of large granular lymphocytes. These show you fine blue granules in the LGLs, similarly in this particular case. And we find a very typical thing on the bone marrow biopsy, their distribution is sinusoidal. Look at the sinusoidal space, and there you will find that the linear rows of these LGLs is present. Now, what is marrow reserve? Now, this is what the marrow reserve is. Here you find the nodular deposit. In between there is fat, and not only fat, you find the megakaryocytes, and hyper you find the myelopoiesis and erythropoiesis. This, of course, is the lymphoma deposit. Here the lymphoma deposit. So what the difference between the two is there is hardly any normal marrow in the diffuse pattern. So the higher the tumor load, low is the marrow reserve, and vice versa. So the prognostic significance of the bone marrow involvement in Hodgkin's lymphoma is that there is a inverse relationship. The cases in which the Hodgkin involves the marrow, you will find that the prognosis is pretty bad in those cases. Now, what happens once we give the chemotherapy to these cases is that the pre-therapy is a hypercellular marrow. There is lymphoma. We give chemotherapy. There is depletion of the lymphoma cells. So there is a reduced cellularity. Once the cellularity reduces, if you do the bone marrow aspirate, it is a diluted aspirate. So what happens then to this marrow is that what you find is gelatinous marrow transformation occurs. It is depleted of the lymphoma cells, few lymphocytes and plasma cells may be seen, and the tumor deposit has disappeared from a mantle cell lymphoma, which was earlier positive for cyclin D1. Then in about 2 weeks' time, the regeneration starts. You find the regenerating megakaryocytes and regenerating erythropoiesis starts in this particular case. So there is a post-chemo hemopoietic regeneration starts occurring in these cases. Few of the cases we find that there are the suspicious cells. That is, the lymphoma deposit has not completely disappeared. If it was a diffuse type, now it is only the focal or nodular type of lymphoma deposit. Then we can use the same markers with which we confirm the diagnosis, say B cell NHL, we confirm that it is CD20 positive. Now, what are the other advantages of doing the bone marrow biopsy is that if there is any other pathology in the bone marrow, or if the patient has got cytopenias and we don't know the cause for cytopenias, bone marrow biopsy may give a clue. Say, for example, in this particular case, the biopsy indicates that it is a hypocellular marrow going towards aplastic. Here we found that the patient had lymphoma, all right, but the patient also had a metastatic carcinoma, and she was found to have a breast cancer. And sometimes we come across tuberculosis with or without causation, the granulomas are seen. Now I go on to the plasma cell disorders. Now we all know that plasma cell proliferations are two types. One is reactive, the other one is neoplastic. Now this is the neoplastic proliferation. The disease starts from a single cell, goes on to MGUS, smoldering multiple myeloma, and then it is a myeloma. Finally, it goes on to plasma cell leukemia. So then this is the neoplastic proliferation, and these plasma cells, these secrete immunoglobulins, and that is what changes the clinical picture in all these cases. So what are the causes of increased plasma cells in the marrow? The reactive plasmacytosis. You can see these plasma cells normal in appearance in the bone marrow, and this could be seen in Kala-azar, metastatic deposits, aplastic anemias, chronic inflammatory disorders, rheumatoid arthritis, sarcoidosis, cirrhosis. Now, how do we differentiate reactive plasmacytosis? Now, the reactive plasmacytosis is usually less than 10%, while the neoplastic could go on to 90%, 95%. Location is very, very important. If we have got a biopsy, we will find that the location of the plasma cells is pericapillary, or it is around the bone marrow arterioles. Then plasma blasts are never seen in the reactive conditions, but plasma blasts could be a type of multiple myeloma. And then these plasma cells which are reactive are polyclonal. That is, some of the plasma cells are kappa positive, the other ones are lambda positive. But the neoplastic plasma cells are either kappa or lambda. Now, this is a pericapillary, this is a capillary, this is a capillary. You find that these plasma cells are CD138 positive and pericapillary in location. Now, the International Myeloma Working Group has given a classification, the criteria for diagnosis for active multiple myeloma, the clonal plasma cells. It doesn't say plasma cells, but clonal. That means either kappa or lambda, more than 10%, and then should have one or more of the CRAB features or one or more of the myeloma defining events. Now, CRAB, we all know, stands for hypercalcemia, R for renal insufficiency, A for anemia, and the hemoglobin could be less than 10 grams. Bone lesions, so CRAB, bone lesions are osteolytic lesions on skeletal radiography, CT, or PET-CT. If the bone marrow has got less than 10% clonal plasma cells, then more than one bone lesion is required to distinguish from the solitary plasmacytomas. Now, what are these myeloma defining events? Myeloma defining events are also known as biomarkers of malignancy. That means it should be the plasma cells which are clonal should be more than 60%. Suppose we find that there is a discrepancy between the number of plasma cells between bone marrow aspirate and bone marrow biopsy, then we go by the higher value, whether in aspirate or in biopsy. Another biomarker is that the free light chain ratio is 100 or more. That means the kappa may be, say, 500, the lambda may be only 5. So the ratio is 500 upon 5. It is 100 is the ratio. So the serum involved upon uninvolved light chain, it should be more than 100. And also the involved light chain should be more than 100 milligram. Now, these are the essential criteria, and more than one focal lesion on MRI, which should be at least 5 millimeters or greater. These are the myeloma defining events. And of course, we find that on serum protein electrophoresis, there is a M band. If we do the immunofixation electrophoresis, which nowadays we do in almost all cases, it gives us an idea about the light chain and heavy chain. Say here we are finding a case where it is G is for gamma. So that means the heavy chain in this particular case is gamma, and the immunoglobulin is IgG type. It is not IgA, it is not IgM type. Now, out of the two, it should be either kappa or lambda. In this particular case, we find it is the kappa. So it is a clonal plasmacytosis in which the immunoglobulin is of kappa type. So the serum free light chains increased will be of kappa type, and it will be IgG type of M protein. These are the serum free light chains, and these of course are the this is a pentamer, This is a dimer, which is IgA. This is in IgM. Now, free light chains are increased even in AMGUS. Free light chains are increased in AMGUS, one-third of the cases. 70% of the smoldering myeloma also show increase of free light chain. And of course, 90% of the myeloma cases show free light chains are increased. If we examine the peripheral smear, we find the rouleau formation, and background indicates that there is a higher globulin. That is what is coloring the background. And here you find that the plasma cells are increased. Now the plasma cells here are larger. They are showing nucleolus. So these are immature myeloma cells or plasma cells. And this is one where you are finding a variation in the cell size, but by and large, they are of intermediate differentiation between the plasma blasts and the plasma cells. And then we find the derangements in the secretion. Here we are finding that the peripheral part of the plasma cells of the cytoplasm is pinkish. That indicates it is a secreting plasma cells and IgA type of myeloma, which is being seen. Here you are finding the crystals inside the myeloma cells. Now, what are the types? Grading is based on the differentiation. Mature type, almost all plasma cells are mature. Here we find that the plasma cells are showing prominent nucleolus. The cells are larger. So this is the immature type, both on the aspirate and in the biopsy, you find there is a prominent single nucleolus. Intermediate differentiation. And then we have the plasma blast. Now, plasma blastic type is sometimes challenged for diagnosis because these appear blastoid cells and may be confused with the blast cells, and one may not even apply CD138 or CD38 for confirming that these are the plasma cells. Prominent nucleolus, open chromatin, and these cases have got the worst prognosis. And then the pleomorphic type. Sometimes these are confused as metastatic carcinoma or metastatic sarcoma into the bone marrow, as you can see in the bone marrow refined biopsy. Therefore, any case where we come across osteolytic lesions, serum protein electrophoresis showing M band, we must do CD38 or CD138 to see. This is a case of 60-year-old physicist who retired from hospital, complained of weakness, loss of weight, and investigations showed anemia. Platelets were reduced, bone marrow aspirate was a dry tap. Now, this is what we got on the refined biopsy. What we find are two things. Number one, there is marrow fibrosis throughout, and that is why we got a dry tap. Second thing is it is a pleomorphic tumor. So first we thought that this could be a case of metastatic carcinoma looking at the morphology of the cells, but the markers for metastatic carcinoma turned out to be all negative. CD38, CD138 were positive, CD61 negative, indicating that we are dealing with a case of anaplastic type of multiple myeloma. This is another case where we found dry tap, and what was there? There was bone marrow fibrosis, there was streaming of the cells. However, the morphology was not clear on gene sustain or on HND, but CD138 came out to be positive, and then we confirmed with anti-kappa, anti-lambda. All the cells were kappa positive, indicating the clonal origin of these cells. So the pattern of infiltration is interstitial or diffuse. Now, why should we do a refined biopsy in multiple myeloma? Number one, you can pick up cases of myeloma with hypocellular marrow also, marrow with fibrosis. Then the cases of amyloid, myeloma or Waldenstrom may be associated with amyloidosis. Those cases can be picked up by doing Congo red stain on the bone marrow refined biopsy. Then the immunohistochemistry is essential to establish the clonality. We have to have either kappa or lambda positive plasma cells to say that it is clonal, and then it fits in with the definition of IMWJ that these are clonal plasma cells which should be seen in these cases. So to demonstrate the clonality, And then we can assess the prognostic markers. Say, for example, the cases with cyclin D1 positive carry a better prognosis. This is the case of multiple myeloma with amyloidosis because we had done the biopsy, so we could pick up that there is associated amyloidosis, and the patient was later on turned out to be a case of nephrotic syndrome also. How to establish the clonality? One is by flow cytometry, but sometimes in about 20 to 25% of the cases of multiple myeloma, we do come across some degree of marrow fibrosis, and therefore we may not get a good aspirate. Immunohistochemistry can confirm by kappa or lambda, and this is on flow cytometry. This is what is on on immunohistochemistry. This is these are the clusters of plasma cells, anti-kappa positive and CD138 positive. Almost all the plasma cells are kappa positive, and these are lambda negative. Few cases we come across plasma cell leukemias where the plasma cells are more than 20% or more than 2000 is the count. MGUS is seen in 2% of the population over 50 years of age. The criteria for diagnosis are well known, that the plasma cells here are less than 10%. So that means we have got three criteria. If the plasma cells are less than 10%, it is likely MGUS. If these are 10 to 60%, it could be smoldering myeloma. If more than 60%, it is multiple myeloma. And the MGUS could be of IgG type, or it could be IgM type MGUS, and also light chain myeloma. Now, light chain MGUS, what we find is that there is abnormal free light chain ratio, and there is no immunoglobulin heavy chain expression on immunofixation. Smoldering multiple myeloma, we find that the risk of progression is 10% in comparison to 1% for MGUS, and 14% of all multiple myeloma cases are actually from smoldering multiple myeloma cases. And now IMWG has given cases criteria for active myeloma by defining the myeloma defining events, so that some cases of which were smoldering multiple myeloma now have been on to the multiple myeloma cases. Here we find that the plasma cells are 10 to 60%, and the plasma monoclonal protein is more than 3 grams, and absence of CRAB features. Once the CRAB features appear or the myeloma defining events appear, even one of them, it becomes a case of multiple myeloma. This is what we find: focal micro aggregates of plasma cells, but then these have to be clonal. So that is a differential diagnosis. Waldenstrom macroglobulinemia is a lymphoplasmacytic lymphoma, but here there is a secretion of IgM paraprotein, and the bone marrow is infiltrated by three types of cells: lymphoid cells, plasmacytoid cells or lymphoplasmacytoid cells, and plasma cells also. And those plasma cells are clonal, associated with hepatosplenomegaly and lymphadenopathy. Bony lesions are uncommon. We may come across a diffuse osteoporosis. This is Waldenstrom macroglobulinemia. This is the M protein. And what we find here is on immunofixation that the heavy chain is mu. So this is the IgM type of protein which is being secreted. And again, it is clonal. So only kappa is positive, lambda is negative. So the Waldenstrom macroglobulinemia we should be aware of. Now we know that MYD88 mutation is seen in almost 90 to 95% cases of Waldenstrom macroglobulinemia. Here what we find is the marrow is replaced by sheets of these lymphoid cells, lymphoplasmacytoid cells, and the plasma cells which are clonal. What we are seeing here are the large granular cells, which are the sea blue histiocytes, which could be seen. And these are the typical lymphoid cells. Then we have these plasma cells, and then lymphoplasmacytoid cells. Three types of cells are seen. So that confirms the diagnosis of CD20 positive, the lymphoid cells are CD20, CD19 positive, and we have the PAX5 positivity. And also what we've come across is that the plasma cells are positive, CD138 positive, and then kappa or lambda, depending upon which one it is. This is plasma cell leukemia. There are certain limitations of immunohistochemistry. It is pretty good for acute leukemias, lymphomas, myelomas. But what we find is that in B cell origin cases, where detection of light chain restriction is a clear indicator of neoplastic infiltration. Say, for example, CLL. If we do flow, we employ kappa and lambda, and we know that all the B cells are either kappa positive or lambda positive. Now, that does not happen as far as immunohistochemistry is concerned. It is okay for plasma cells because what we are using is that the receptor is present in the cytoplasm. So we use the permeabilizing agent and we infiltrate through the cell membrane, reach the cytoplasm, and the plasma cells come out to be positive. This is one of the limitations which we come across in immunohistochemistry. So what is suggested is that we should carry out for staging bone marrow defined biopsy and all cases of B and T cell non-Hodgkin's lymphomas, and also cases of anaplastic large cell lymphoma, especially cases where there is a dry tap and there is a bone marrow fibrosis. A positive marrow upstages the case to stage 4, and hence there is a need for bone marrow biopsy because then these cases are treated as case stage 4. And then post-chemotherapy biopsy is very useful in evaluation of residual lymphoma, hemopoietic regeneration, and any other pathology. So at times we find that the IHC analysis markers, they detect morphologically inapparent marrow involvement sometimes, especially in about 11% of the cases. So therefore, the bone marrow biopsy can provide accuracy of the diagnosis and subtyping. And of course, the ancillary techniques like flow cytometry and cytogenetics and molecular have to be part of the diagnostic workup. So immunohistochemistry analysis using B and T cell markers detects morphologically inapparent disease as well. Thank you very much. Thanks a lot.
Thank you, sir. Fantastic talk as always. Always good to listen to you, and it's a worth learning from you, sir. Thank you so much.
Thank
Sir,
you.
yeah, can you please, sir, share your screen once so that we can start our question session? Yes, so I request all our discussants to please put the hand raise signs so that we can start our question session with Dr. Tajendra Singh, sir. Yes, Dr. Shilpi, your question, please.
Thank you, sir. Thank you for the enlightening presentation. And especially the emphasis on the importance on bone marrow biopsy in picking up other pathologies apart from lymphoma. And the case of anaplastic myeloma was very interesting. Sir, I have had few cases in past coming with splenomegaly and cytopenia. These were 40 to 45-year-old men. So peripheral blood showed occasional abnormal lymphocyte bipolar cells, which were less than 5% on morphology. And bone marrow aspirate also, although adequate, but showed less than 5% such lymphocytes on morphology. However, the flow cytometry revealed around 3.5% of CD20 positive, 10 negative, 5 negative, 23 negative, 25 negative, 103 negative, 123 negative, 38 negative kappa restricted cells. In this case, sir, actually bone marrow biopsy showed only scattered interstitial CD20 positive B cells. So my question is, sir, in such cases, do you agree that flow cytometry would be a better as compared to bone marrow biopsy? And what percentage of CD20 positive cells would you take in bone marrow biopsy to call it malignant or involved by lymphoma?
Okay. See, both the investigations are complementary.
Sir.
If you are finding atypical cells in the peripheral blood, it makes a diagnosis that we are dealing with a case which is neoplastic. That is one. Second thing, these cells could be hairy cells also, because we don't know. These are lymphoid cells. These cells could be hairy cells. These could be cells of the splenic marginal zone lymphoma also.
Yes.
However, the biopsy would indicate how much fibrosis is present, because the patient has got spleen. Patient has got splenomegaly. So we have
Yes.
to see how much fibrosis is there. Now, if we are getting less cells, fewer cells on bone marrow aspirate, that means there is a marrow fibrosis which is occurring. I think it will be worthwhile doing bone marrow trephine biopsy, which is adequate one, and trying the markers both for hairy cell leukemia and as well as for splenic marginal zone lymphoma. Cutoff point for percentage of B cells. Now, as far as the cutoff is seen, say which cells are more in the bone marrow. Normally, we find that the T cells are more. CD3 positive cells are twice the number of B cells.
Yes.
However, in cases if you have lymphoid follicles, here the age is about 45, you mentioned. But
Yes,
if
sir.
you find that there are cells which are present, more likely CD3 positive. If CD20 cells are majority, we are sure that we are dealing with a B cell neoplasm, but needs to be proved by monoclonal antibodies.
Sir. And sir, my second question is your experience with kappa lambda ish.
Kappa lambda and?
Kappa lambda ish, sir, in situ hybridization.
No, I am not doing in situ hybridization, so I won't be able to comment on that. We are doing kappa lambda
And
immunohistochemistry, both
okay, sir.
on, we are doing only on myeloma cases. We are not doing in cases of
Lymphoma.
CLL or other non-Hodgkin lymphomas. And for multiple myeloma, we are getting pretty good results as far as kappa lambda are concerned. And based on that, we have been diagnosing myeloma cases. Once we diagnose as myeloma cases, then we are going for molecular studies.
Yes. Thank you so much, sir.
Thank you.
Thank you, Dr. Shilpi. Somebody as DIMM, can you please open up your video? Yeah.
Good evening, sir. Sorry, my name is not shown correctly there. Some problem with the login. I am Dr. Rashmi Kushwaha from Lucknow. I would like to congratulate sir for such an exhaustive and wonderful talk, and you've almost covered everything. And regarding that Hodgkin's lymphoma, which you caught up on the trephine biopsy with fibrosis. So even we came across a similar case, like peripheral blood and bone marrow aspirate was normal. And we, in that case, there was lot of marrow fibrosis and some large cells with prominent nucleoli. And when we put CD30 stain on it, it came beautifully positive. So we picked up actually Hodgkin's from there, and then retrospectively the patient was evaluated and he had retroperitoneal lymphadenopathy. So, I mean, this is like quite helpful, the trephine biopsy in fibrotic cases, and especially when aspirate is diluted, then again it gives a indication that there could be fibrosis in the marrow. So, very nice case.
In this context, I would share my experience that we started doing trephine biopsy in 1978. We have reported hundreds of cases of Hodgkin's, non-Hodgkin involvement of the bone marrow. But I have reported only 3 cases in which we could detect marrow involvement by Hodgkin's on bone marrow aspirate. And all those 3 cases were immunosuppressed. So in immunosuppression, fibrosis does not occur, and therefore we may get on good bone marrow aspirate. But in cases where there is no immunosuppression, fibrosis is nearly 100% positive in Hodgkin's lymphoma.
Okay, sir. Thank you so much, sir.
Thank you.
Thank you, Dr. Rashmi. So there are some questions from the audience.
Yes.
The first question is from Dr. Piskila. How to differentiate between LPL from marginal zone lymphoma in trephine biopsy using IHC?
Now, LPL, see, lymphoplasmacytic lymphoma from marginal zone lymphoma. See, LPL is, if we are talking of lymphoplasmacytic lymphoma with IgM secretion, what we call as Waldenstrom macroglobulinemia. Then, of course, the morphology is typical lymphocytes, plasmacytoid lymphocytes, and plasma cells, which are clonal. That is important. And next component is that the secretion of IgM that is essentially required for diagnosis of Waldenstrom macroglobulinemia. On the other hand, if there is involvement only of the lymph node, not of the bone marrow, then IgM secretion does not occur. Then we have to report only the lymphoma part because the IgM secretion is not taking place. On the other hand, the splenic marginal zone lymphoma, which she has mentioned, that is a CD20 positive B cell non-Hodgkin's lymphoma. And as I was discussing, I said there is somehow there is no specific marker for splenic marginal zone lymphoma. What is specific is the longitudinal hairy processes which we come across in a peripheral smear in cases of splenic marginal lymphoma. That is why we used to call it earlier as SLVL, splenic lymphoma with villous lymphocytes. That is a B cell lymphoma, and only CD20, CD19, CD79A. These are the markers which are positive. No question of CD138, which is positive in cases of lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia. And then, of course, now we know that MYD88 mutation is the characteristic feature of Waldenstrom macroglobulinemia.
Thank you, sir. Another question is from Dr. Hitha B. In a low-grade lymphoma, the lymph node morphology shows diffuse effacement with the low-grade lymphoma cells. And the peripheral smear was showing 17,000 WBC count, out of which 6% were atypical lymphoid cells and 20% looks like reactive lymphocytes. So which will be better for diagnosis? Whether lymph node biopsy in IHC, or the peripheral blood flow cytometry if the patient is not willing for bone marrow?
See, as far as lymphomas are concerned, the Lugano classification and the criteria say that the lymph node biopsy with immunohistochemistry is a gold standard. So I think the other things become secondary. Once we have a peripheral lymph node and it is removable, go ahead and do the lymph node removal with immunohistochemistry and diagnose on that basis.
Perfect, sir. Another question is from Dr. Hithabi again. In a bone marrow with 20% plasma cells and serum protein immunofixation and the urine protein immunofixation is both are negative, and if clonality has to be established by kappa or lambda, IHC of marrow alone, is there any cutoff to define this differential positivity? How much should be the kappa and how much should be the lambda?
See, there are various studies in which they have mentioned that how many plasma cells should be positive and how many should be kappa positive or how many should be lambda positive. The highest ratio which has been mentioned is 16:1. In some other studies, they have mentioned a ratio of 9:1. That is, the plasma cells which are kappa positive should be 16 and the lambda positive should be 1. By and large, what we have seen is that in a case of myeloma, we find that almost all the cells in the bone marrow are either kappa positive or lambda positive, and by and large, there is no problem in differentiating. Where does the problem come? The problem comes in diagnosing smoldering myeloma because the number of plasma cells is few. And that is where, suppose we find 12 plasma cells, 14 plasma cells, that is where the problem comes. And that is where we have to see the ratio. If we go by the highest ratio, they have mentioned is 16:1. So let us go by that.
So 9:1 is also okay, sir?
Yes, somebody has mentioned 9:1, but that study was on about 500 cases. The 16:1 is a study of more than 1,000 cases where they have mentioned that.
Thank you, sir. Another question is from Dr. Yimon Tent. About she has asked about TCR beta constant 1, that is TRBC1, sensitivity and specificity without the molecular test of TCR gene rearrangement. What should be the significant percentage cutoff to say it is TCL gene rearranged with the help of TRBC1?
See, in T non-Hodgkin lymphoma, sometimes there is a problem to say, is it just T cell lymphocytosis or is a T NHL, especially the peripheral T cell lymphoma? Say, for example, I see large granular lymphocytes in the peripheral blood. I see large granular lymphocytes in the bone marrow. Now, is it a LGL leukemia or is it a just LGL increased? Now, that is where the role of T cell receptor gene studies come to differentiate between a benign condition and a malignant condition, because one would entail a neoplasia like TLGL or maybe some peripheral T cell lymphoma. Those are the cases where the T cell receptor studies need to be carried out. I don't carry out T cell receptor studies, so I won't be able to comment much on that.
So any cutoffs are percentage wise?
I'm not aware of. There must be some percentage, but I'm not aware of.
When this question was asked, I just checked the Google. It's showing us about 85% should be the cutoff for
Okay.
positivity and 10 to 15% should be negative.
Okay.
So
Right.
85 to 90% cutoff for positivity, 10 to 15% should be negative.
Negative. Thank you. Thank you, sir.
It was just saying. One question has come from Dr. Myat Mallersway. As there is no specific marker for splenic marginal zone lymphoma, could you please share your experience with the diagnosis of splenic marginal zone lymphoma? How to diagnose? What all markers must be positive to diagnose SMZL?
See, we have diagnosed many cases of splenic marginal zone lymphoma based on number one, peripheral smear examination. In almost all but one case, there was spillover into the peripheral blood, and we could see the hairy processes which were in the direction in which the smear is made were positive. Almost all the cases did show PS positivity in the cytoplasm. Then these were all CD20, CD19 positive B cell lymphomas. And in two cases, we could get the splenectomy done. And I've shown one case in which the other one also was similar. There were tiny whites, nodules of lymphoma present in the spleen. And the spleen was moderately enlarged in all the cases. As I mentioned, there is no specific marker for for splenic marginal zone lymphoma. So we go by the B cell markers to establish. It is something like by ruling out all other lymphomas, like we do CD5, CD23, CD10, all these should be negative. Markers for hairy cell leukemia should be negative. Then we label it as, and fitting with the clinical picture and the peripheral blood showing those hairy processes, we label it as a case of splenic marginal zone lymphoma.
Sir, on the bone marrow biopsy, anything typical for the morphology of SMZL on bone marrow biopsy?
No, there is none. There is none.
Any intrasinusoidal pattern will not give a clue?
No. Intracellular we find in lymphoplasmacytic lymphomas cases where we find Dutcher bodies inside the nucleus.
No, intrasinusoidal pattern.
No, intrasinusoidal pattern is seen in some cases,
Okay.
but intrasinusoidal pattern is also seen what I showed you, the LGL cases also. Intrasinusoidal pattern is also seen in some cases of mantle cell lymphoma also. It is not the classical picture for splenic marginal zone lymphoma.
Thank you, sir. Dr. Rashmi, a question, please.
Sir, is there any way how to quantify the number of plasma cells on that refined section? Many a times the clinician asks it refined section mein what is the percentage of plasma cells you are seeing, or should we just report as number of plasma cells seen per high power field?
See, we always report the number of plasma cells on immunohistochemistry. We do CD138 because what we have seen is that in our lab, CD138 is a better marker for plasma cell enumeration as compared to CD38. So we do CD138 and then count about anything between 500 to 1000 cells. What we do is take care is that we do hematoxylin 2 minutes longer so that the nuclei of the other cells is well made out, so that you can count CD138 positive cells. Incidentally, plasma cells are larger and
Yes.
all of them will show a membrane positivity. Therefore, it is very easy to pick up these CD138 positive large plasma cells and differentiate them from rest of the cells where we have given longer hematoxylin so as to make out the nature of the cells. So it is very easy. You
Okay.
can
So
start it
ideally,
from tomorrow onwards.
sir, so ideally on the tryptophan section biopsy reports also, we should mention the percentage of plasma cells, right?
We mention the percentage of plasma cells when we have done CD138.
138. Okay.
If they want only on HND, then we usually don't mention,
Okay.
because sometimes some plasma cells may be hidden behind the erythroblasts or maybe behind the myeloid cells or maybe behind the lymphocytes. So then it becomes a problem. We may think that there are 10% plasma cells, but once you do CD138, you find no, these were not 10%, these were about 20% of plasma cells.
Yes, sir.
So please report it only if you are doing CD138. Very easy to count.
Okay. Fine, sir. Thank you, sir.
Thank you, Dr. Rashmi. Anybody has any other question? Because I have finished all the questions from the chat box. Well, so in that case, sir, thank you so much.
Thank you.
Fantastic lecture, wonderful lecture, good learning from you.
Right.
Superb, sir. And
Okay.
also thanks for all our discussants to participate in this webinar. Meet you tomorrow at 11:30 a.m. Thank you so
Sure.
much.
Okay. Thank you so much, Dr. Khurana. Thanks a lot.
Thank you, sir.